Bismillah ar-Rahman ar-Rahim. Pulmonary hypertension. The definition: pulmonary hypertension is a hemodynamic and pathophysiological state that can be found in multiple clinical conditions. The normal resting mean pulmonary artery pressure is around 14 mm mercury, and a pressure above 20 mm mercury is roughly 2 standard deviation from the normal mean pulmonary artery pressure. Pulmonary hypertension is defined as a mean pulmonary artery pressure more than or equal to 20 mm mercury at rest as assessed by right heart catheterization. Although this definition is lower than the current treatment threshold of above 25 mm mercury, clinical trials are ongoing at lower threshold. In clinical groups 1, 3, and 4, the pulmonary artery wedge pressure is normal at below or equal to 15 mm mercury, but the pulmonary vascular resistance is raised more than 3 Wood units. In group 2, pulmonary artery wedge pressure is more than 15 mm mercury and can be raised in group 5. Resting pulmonary hypertension is significant as more than 70% of the vascular bed must be lost for the pulmonary artery pressure to rise. Pathophysiology: each group has differing characteristic pathological feature, but vasoconstriction, remodeling of the pulmonary vessel wall, medial hypertrophy of distal pulmonary arteries, plus or minus fibrotic change, and thrombosis lead to raised pulmonary vascular resistance and ultimately right heart failure. An imbalance between nitric oxide and prostacyclin, a potent vasodilator and platelet inhibitor, and thromboxane A2, which is a potent vasoconstrictor and platelet agonist, has been identified in pulmonary arterial hypertension. Unfavorable imbalances between other regulators of vascular tone and smooth muscle cell growth, including endothelin 1, nitric oxide, and serotonin, have also been implicated. Presenting, presenting features of pulmonary hypertension. The symptoms of pulmonary hypertension are primarily due to a right ventricle dysfunction. The symptoms are nonspecific, often lead to a delay in diagnosis from first symptoms, exertional restlessness due to the inability to increase cardiac output and exercise, World Health Organization functional assessment classification used to quantify. There is chest pain, right heart angina, fatigue and weakness, syncope or pre-syncope due to fall in systemic blood pressure on exercise, palpitations, exertional edema, and other signs of right side fluid overload. The examination of pulmonary hypertension reveals signs of right heart fluid overload and right ventricular hypertrophy and are associated with advanced disease and include right ventricle heave and right ventricle third sound, wide splitting of second sound with loud P2, pansystolic murmur of the tricuspid regurgitation, diastolic murmur of pulmonary insufficiency, raised jugular venous pressure and giant V waves, hepatomegaly, ascites and peripheral edema, cyanosis, and possible telangiectasia, digital ulceration, and sclerodactyly and pulmonary hypertension associated with scleroderma, stigmata of chronic liver disease with portal hypertension, clubbing suggests interstitial lung disease or congenital heart disease, lungs normally clear unless underlying interstitial lung disease in association with connective tissue disease or a pulmonary edema associated with pulmonary veno-occlusive disease. Updated clinical classification of pulmonary hypertension. First, pulmonary artery hypertension, which may be idiopathic or heritable, drug and toxin induced, associated pulmonary arterial hypertension, such as in connective tissue disease, human immunodeficiency virus, HIV, portal hypertension, congenital heart disease, schistosomiasis, pulmonary arterial hypertension, long-term responders to calcium channel blockers, pulmonary veno-occlusive disease, and pulmonary capillary hemangiomatosis, persistent pulmonary hypertension of the newborn. Second, pulmonary hypertension due to left heart disease and includes the following: pulmonary hypertension due to heart failure with preserved ejection fraction, pulmonary hypertension due to heart failure with reduced ejection fraction, valvular disease, congenital or acquired cardiovascular conditions leading to post-capillary pulmonary hypertension, congenital or acquired pulmonary vein stenosis. The third, pulmonary hypertension type due to lung disease and or hypoxia and include chronic obstructive pulmonary disease, interstitial lung disease, other pulmonary disease with mixed restrictive and obstructive pattern, sleep disorders, breathing, alveolar hypoventilation syndrome, chronic, chronic exposure to high altitude, developmental abnormalities. The fourth type is chronic thromboembolic pulmonary hypertension and other pulmonary artery obstructions, include chronic thromboembolic pulmonary hypertension and other pulmonary artery obstructions such as angiosarcoma and other intravascular tumors, arthritis, congenital pulmonary artery stenosis, parasitis such as hydatid disease. The fifth type is pulmonary hypertension with unclear and or multifocal or multifactorial mechanisms and include the following: hematological disorder such as chronic hemolytic anemia, myeloproliferative disorders, splenectomy, systemic disorders such as sarcoidosis, pulmonary histiocytosis, lymphangioliomyomatosis, neurofibromatosis, metabolic disorders such as glycogen storage disease, Gaucher disease, thyroid disorders, others such as pulmonary tumor thrombotic microangiopathy, fibrosing mediastinitis, chronic renal failure, with or without dialysis, segmental pulmonary hypertension. Investigations of pulmonary hypertension. The investigations aim to make a diagnosis of pulmonary hypertension and investigate any possible underlying cause, and in 85 of patients presenting with symptoms caused by established pulmonary hypertension, a chest X-ray and electrocardiogram will be abnormal. Chest X-ray may show enlarged pulmonary arteries and an enlarged cardiac silhouette with proning loss of peripheral vessels. The ECG will reveal right atrial dilatation, right axis deviation, right ventricular hypertrophy, and strain. Arterial blood gases may show slight hypoxia and hypocapnia correlating with disease severity with a fall in auto saturation on exercise. Pulmonary function tests, the lung volumes may be normal or show a mild restrictive or obstructive defect with a reduced total lung carbon monoxide transfer factor TLCO, abnormal if pulmonary hypertension due to underlying lung disease. The high resolution computed tomography of the chest to exclude the underlying lung disease, which may be COPD or interstitial lung disease. The ventilation perfusion scanning and computed tomographic pulmonary angiogram to exclude chronic thromboembolic disease as the cause. The ventilation perfusion is more sensitive than CT pulmonary angiogram. Normal or low probability VQ scan effectively exclude chronic thromboembolic pulmonary hypertension. Echocardiogram echo, the most useful screening tool in pulmonary hypertension, typically shows enlargement of right side cardiac chambers with paradoxical interventricular sept- septum movement and tricuspid regurg. The systolic pulmonary artery hypertension can be estimated from the peak velocity of the tricuspid regurgitant jet using Doppler techniques and estimated right arterial pressure from the inferior vena cava, assumed to be 5 to 10 millimeter mercury. The echo probability of pulmonary hypertension can be categorized dependent on the velocity of tricuspid regurgitant jet and low probability if below or equal to 2.8 milli per second or not measurable and no other pulmonary hypertension signs. Intermediate if below or equal to 2.8 milli per second or not measurable and no other pulmonary hypertension signs. Intermediate if below or equal to 2.8 milli per second and other pulmonary hypertension signs, or if 2.9 to 3.4 milli per second without other pulmonary hypertension signs, and the high if 2.9 to 3.4 milli per second with other pulmonary hypertension signs, or if more than 3.4 milli per second. Pericardial effusion may present and present worsen or worse prognosis. Bubble echo can help to exclude an intracardiac shunt and also increase the Doppler signal, allowing either measurements of peak tricuspid gauge velocity. Cardiac magnetic resonance imaging (MRI) to evaluate right ventricle size, morphology, and function. Abnormal ultrasound scan if liver cirrhosis or portal hypertension suspected. Right heart cath if the gold standard test to confirm diagnosis. Assesses the pulmonary artery pressure, pulmonary capillary wedge pressure, and the cardiac output with the Swan Ganz catheter. The thermodilution, or FEC, also can exclude a left to right intracardiac shunt. Vasodilator responsiveness is measured with incremental doses of a short-acting vasodilator such as inhaled nitric oxide or intravenous epoprostenol or adenosine. A positive vasodilator response is defined as a drop in mean pulmonary artery pressure by more than 10 millimeter mercury to below 40 millimeter mercury with an unchanged or increased cardiac output. Only about 5 to 10% of patients are responders. 6-minute walk test for objective assessment of exercise capacity. Walking distances of below 300 meter and auto desaturation of more than 10% indicate worse prognosis in pulmonary artery hypertension. Increase in 6-minute walk test distance following treatment used to often used in assessment and in trials but may not be the best outcome measure of pulmonary hypertension subgroups. Cardiopulmonary exercise testing, oxygen uptake at anaerobic threshold and peak exercise are reduced in relation to disease severity. Selective pulmonary angiography is rarely required as CTPA and VQ and can detect nearly all cases of thromboembolic disease. Blood tests, routine tests including HIV test, thyroid stimulating hormone, angiotensin converting enzyme, autoantibodies, anti-centromere antibody, and scleroderma CSL70 and ribonuclease protein. If connective tissue disease suspected thrombophilia, screen in chronic thromboembolic pulmonary hypertension. Brain natriuretic peptide BNP plasma level if elevated associated with worse prognosis of pulmonary hypertension.